Welcome back to the deep dive. Today, we are going to do something a little different. We're going to focus on a single, very high-pressure moment. I want you to just visualize this. You're standing right outside the exam hall. Maybe it's a Gujarat University. Maybe it's for the National Board in Delhi. Your palms are sweating a bit.
We've all been there.
Exactly. And you're about to walk in and face a senior professor on the most fundamental topic in our specialty, the airway.
It really is the ultimate make or break moment, isn't it? I mean, you can know everything about, say, cardiac output or pharmacokinetics, but if you fumble the anatomy of the larynx,
You're done.
You are done. If you can't identify the cricothyroid membrane on a model, it's over. It's, as they say in Miller, the primary responsibility. Failure here leads to hypoxic brain injury or death in minutes. It's that serious.
And that is exactly our mission for this deep dive. We're not just, reading from a textbook. We're going to act as your senior faculty, your study partners. The goal is to turn those dry anatomical facts into what you need for a 20-mark gold standard answer. We're going to map the airway from the tip of the nose right down to the trachea.
And we'll hit the pharynx, the larynx, and of course those emergency surgical access points that everyone worries about.
And we had to do this strategically. The structure of this conversation should be exactly how you would structure an answer in a theory paper or how you'd present it in a Viva.
Absolutely. It's not just listing bones and muscles. It's about connecting every single landmark to what we do. Mask, ventilation, intubation, and that dreaded cannot intubate, cannot ventilate scenario.
So let's begin where the air begins, the upper airway. Let's talk about the nose. Now, day to day, we might just think of it as a place to, rest a mask.
Yeah, but for the exam, the nasal cavity is a minefield of potential questions. It's extremely high yield.
Why so high yield?
Because of one thing, mainly. Nasal intubation. You have to understand the architecture. So you have the external nose, bony on top, cartilage at the bottom, but the real money is on the inside.
Right, inside the cavity.
The nasal septum divides it down the middle. That's the ethmoid and vomer bones. But for us, the anesthetist, the action is all on the lateral walls.
You're talking about the turbinates.
Correct. The conchae, or turbinates, you have three. Superior, middle, and inferior. Think of them as these little bony shells.
And they increase the surface area for humidification and warming the air.
Exactly. But crucially, underneath each turbinate, there's a space, a meatus.
And this is probably the first exam trap. If an examiner asks you to describe the path of a nasotracheal tube, you can't just say, I'll push it in.
Oh, absolutely not. You have to be specific. You must state that you are aiming for the inferior meatus.
The space below the inferior turbinate.
Yes. It's the largest and it's the path of least resistance. You have to pass the tube along the floor of the nose. If you aim upwards, you're going to hit the middle turbinate.
And it causes bleeding.
A lot of bleeding. Or worse, if you go way too high, you could theoretically hit the Kruger-form plate.
Which is why we avoid nasal airways in basilar skull fractures.
Yeah.
You don't want to be intubating the brain.
Precisely. Stick to the floor. Now, the other massive topic here, still in the nose, is the blood supply. The nose is incredibly vascular.
And examiners love asking about epistaxis. Nosebleeds.
They do. And they're not looking for a vague answer like it bleeds a lot. They want a specific name.
Kieselbach's plexus.
Or Little's area. Same thing. You need to know where it is on the antero-inferior part of the nasal septum.
And you need to know which arteries form it. Right?
Yes, this is a classic short note or Viva question. It's a specific anastomosis. So for the exam, you should be able to rattle them off. It's the septal branches of the superior labial artery, the anterior ethmoidal artery, and the sphenopalatine artery.
The book, Anatomy for Anesthetists, says this is the source of 90% of nosebleeds.
It is. Which brings us to the clinical application. Preparation. This is why we use vasoconstrictors before we even think about putting a tube in the nose.
Things like oxymetaline or phenylephrine drops.
Right. Or traditionally, a cocaine pack. You're trying to shrink the mucosa over this specific plexus to minimize the risk of hemorrhage.
And what about the nerve supply? Just quickly, for something like an awake fiber optic intubation.
It's pretty simple if you divide the nose in two. The anterior part, that's the anterior ethmoidal nerve, which is a branch of V1, the ophthalmic division.
Okay, V1 in the front.
And the posterior part, which is the larger area, that's from the maxillary division, V2, through the sphenopalatine ganglion.
Got it. So that covers the nose. Let's move posteriorly from there into the pharynx, a muscular tube, about 12 to 14 centimeters long?
Yep. And we divide it into three parts: nasopharynx, oropharynx, and the laryngopharynx or hypopharynx.
So starting at the top, the nasopharynx, from the base of the skull down to the soft palate.
Right, and there are two key landmarks here for us. First, on the lateral wall, you have the opening of the eustachian tube.
Okay.
But more importantly, on the roof and the posterior wall, you have the pharyngeal tonsils. You probably know them as the adenoids.
Adenoids are a huge deal in pediatric anesthesia.
Oh, absolutely. Adenoidal hypertrophy is a major cause of obstructive sleep apnea in kids. But the anatomical risk, and this is mentioned in O's intensive care, is during blind nasal intubation.
What's the risk?
If you just force a tube through, you can literally shear off a chunk of that adenoidal tissue. It's extremely vascular, so you get massive bleeding.
Or aspiration of the tissue itself.
Exactly. It can fall down and completely occlude the glottis. It's a disaster.
Okay, moving down into the oropharynx, this is the part we can see when a patient opens their mouth. From the soft palate down to the tip of the epiglottis.
This is what I'd call exam core. This is where we do our initial airway assessment. The key structures to identify are the palatine tonsils.
And they sit between those two muscular arches, the falcial pillars.
Correct. You have to know them. The paltoglossal arch is the anterior one, and the paltopharyngeal arch is the posterior one.
And recognizing those pillars is the entire anatomical basis for the Malpati classification, isn't it?
It is. A lot of people just memorize the pictures, but they don't understand the anatomy behind it.
So let's break that down. What's the logic?
The logic is that we are trying to assess the size of the tongue relative to the size of the oral cavity. If the tongue is huge, it's going to obscure your view of the pharyngeal structures.
Right.
So class 1, you can see everything. The soft palate, the fauces, the uvula, and crucially, both the anterior and the posterior pillars. It's a wide open view.
Class 2.
In class 2, the tongue is a bit bigger, so it hides the pillars. You can still see the soft palate, fauces, and the uvula clearly.
Okay, then for class 3, the tongue is even bigger.
Much bigger. Now you can only see the soft palate and just the base of the uvula. The rest is hidden.
And class 4 is the worst view.
Right. Class 4, you can only see the hard palate. The tongue is so large it's obscuring everything else.
And the whole point of this is to predict the view you'll get during laryngoscopy.
Exactly. It correlates with the Cormack-Lefane grade. A Malpati III, or 4V, strongly suggests that the tongue is going to flop back and obscure your view of the laryngeal inlet, making intubation more difficult.
Also in the oropharynx, you have the soft palate and the uvula. When a patient is under anesthesia, they lose muscle tone.
And that's critical. The soft palate falls back against the posterior pharyngeal wall. That's a common cause of obstruction.
And that's the anatomical reason why a jaw thrust works, or why an oropharyngeal airway works.
Precisely. You're physically lifting those structures off the posterior wall to create a patent airway.
Okay, last part of the pharynx, the hypopharynx, or laryngopharynx. This goes from the tip of the epiglottis down to the cricoid cartilage around the C6 level.
The one landmark you absolutely must know here for your Viva is the piriform fossa.
Can you describe that for us? Let's try to visualize it.
Okay, imagine the laryngeal inlet, the entrance to the larynx, rising up in the middle of the pharynx. On either side of that entrance, there's a deep gutter, a depression. That is the piriform fossa. It's bounded medially by the aryepiglottic fold and laterally by the thyroid cartilage.
And this is a Viva favorite for a couple of reasons.
Two main reasons. First, it's a very common site for foreign bodies to get lodged. Think fish bones, things like that.
And the second reason.
The second, and the one that is critical for us, is that the internal laryngeal nerve runs just underneath the mucosa in the floor of the piriform fossa.
So this is where you perform a piriform fossa block.
Exactly. If you're doing an awake intubation, you can take Krause's forceps with a pledget soaked in local anesthetic, and you just hold it in that gutter for about a minute.
And that will anesthetize the upper larynx.
It blocks the sensory supply to the larynx above the vocal cords. It's a cornerstone technique.
Well, that's a perfect transition into part C, the larynx itself. If the airway is a movie, this is definitely the main character.
Without a doubt. The larynx is the protective valve of the airway. It sits opposite the C3 to C6 vertebrae.
If you get that 20-mark question, describe the anatomy of the larynx. How should you structure it?
You need a clear structure. Start with the cartilages, then the ligaments and membranes, then the interior of the larynx, which means the vocal cords, and finally, the innervation.
Okay, let's hit the cartilages, just the high-yield ones.
There are three main unpaired cartilages: thyroid, cricoid, and the epiglottis, and three smaller paired ones: the arytenoids, corniculates, and cuneiforms.
The thyroid cartilage is the big one, the shield. The Adam's apple.
Yes, but for the anesthetist, the most important cartilage, the one you must know inside and out, is the cricoid cartilage.
Why does the cricoid get top billing?
For one very simple, very important reason, it is the only complete cartilaginous ring in the entire airway.
The only one.
The only one. The tracheal rings are C-shaped, they're incomplete posteriorly. The thyroid cartilage is just a shield in the front, but the cricoid is a full circle.
And it's shaped like a signet ring, right?
Exactly. A narrow arch in the front and a broad, flat lamina in the back.
And that complete ring structure is the whole anatomical basis for applying cricoid pressure.
Selleck's maneuver. Because the ring is solid, when you press that anterior arch backwards, the posterior lamina compresses the esophagus, which lies directly behind it, against the vertebral column.
And in theory, that prevents gastric contents from coming up.
That's the theory. Now, modern guidelines have debated its efficacy, but for your exam, you must be able to explain the anatomical basis. A complete ring allows for compression of the esophagus.
Okay, then we have the arytenoids, the small paired cartilages.
Yes, these are little pyramids that sit on top of the posterior part of the cricoid lamina. They are the key to the mechanics of the voice and breathing because the vocal cords attach to them posteriorly. So when the arytenoids slide or they rotate or they rock back and forth, they are what open and close the vocal cords.
Which brings us to the vocal cords themselves.
Right. So inside the larynx, you have the false cords or vestibular folds superiorly. And then inferiorly, you have the true vocal cords.
And they look different on laryngoscopy.
Very different. The true cords are a pearly white glistening color. The space between them is called the rima glottis.
Now, I want to pause here on a classic exam question, a point of confusion. The narrowest part of the airway.
Ah, yes. The viva landmine. You have to be careful how you answer this.
So what's the safe, exam-proof answer?
Here's the safe path. In adults, the narrowest part is the glottis, the opening between the vocal cords themselves.
And in children?
In children, the traditional teaching, and the one you should stick to in an exam, is that the narrowest part is the cricoid ring, the subglottic area.
That's why we traditionally used uncuffed tubes in kids to avoid pressure damage at the cricoid.
Exactly. Now, there is newer evidence suggesting the glottis might be the narrowest part in kids too. But for the exam, don't argue with the examiner, stick to the dogma. Adult equals glottis, child equals cricoid.
Got it. Now for the part where I've seen even good students just crumble, the innervation of the larynx.
You have to have this lockdown cold. It's all from one cranial nerve, the vagus nerve, cranial nerve 10.
But it's the branches that matter. The superior laryngeal nerve and the recurrent laryngeal nerve.
Let's break down the superior laryngeal nerve, or SLN, first. It comes off the vagus, and then it divides into two branches, an internal and an external branch.
Right.
The internal branch pierces the thyrohyoid membrane to get inside the larynx. It is purely sensory. It supplies sensation to the larynx above the level of the vocal cords.
And the external branch.
The external branch stays outside. It is purely motor. And it supplies exactly one muscle, the cricothyroid muscle.
There's good mnemonic for that, isn't there? Internal is inside for sensation, external is for exercise.
That's a great way to remember it. And what does the cricothyroid muscle do? It's the tensor of the vocal cords. It stretches them, which is how you produce high-pitched sounds.
So if you injure that external branch, say during thyroid surgery.
The patient can't hit high notes. Their voice becomes monotonous, husky.
Okay, that's the SLN. Now the workhorse, the recurrent laryngeal nerve.
The RLN. It's called recurrent because it takes a long path. It goes down into the chest and then loops back up to the larynx.
And its function.
It does two things. It provides sensory innervation to the area below the vocal cords, and here's the big one. It provides motor supply to all the other intrinsic muscles of the larynx.
So all the muscles that open and close the cords, the abductors and the adductors.
All of them. The posterior cricoridinoids, which are the only abductors, the only muscles that open the cords, are supplied by the RLN. The adductors, which close the cords, also RLN.
And this anatomy is what dictates the clinical picture when these nerves get injured.
Absolutely. This is a guaranteed vivastation. Let's walk through the injury patterns. First, a unilateral RLN injury.
So one nerve is cut.
Right. The vocal cord on that side is paralyzed. It usually sits in a halfway position, what we call paramedian. The other, healthy cord, can cross the midline to compensate a bit.
So what's the symptom?
Hoarseness. A breathy, hoarse voice.
Okay, but a bilateral RLN injury is a completely different story.
It's a catastrophe, an airway emergency. If both RLNs are cut, then both of the abductor muscles, the openers, are paralyzed.
But the cricothyroid muscles are still working. because they're supplied by the SLN.
Precisely. And the cricothyroids are tensors, and they also have a weak adductor action. So they pull the now paralyzed vocal cords together towards the midline.
So the airway is almost completely closed.
It creates a valve effect. The patient has acute airway obstruction and stridor. You need to intubate or secure that airway immediately. It's life-threatening.
That's such a crucial distinction. Unilateral is hoarseness, bilateral is obstruction.
You must know that.
Okay, moving past the larynx, we enter the lower airway. Let's talk about the trachea.
The trachea, or windpipe. It extends from the lower border of the cricoid cartilage at C6 down to the carina.
And the carina is at the level of the sternal angle, the angle of Louis, about T4 or T5.
Correct. It's about 10 to 12 centimeters long in an adult, and it's not just a rigid tube.
It has those cartilaginous rings.
About 16 to 20 of them, but, and this is a key anatomical point, they are C-shaped. They are incomplete on the posterior side.
Why does it matter so much to us?
Because the posterior wall is just a soft membranous wall with the trachealis muscle. Yeah. And what lies directly behind that soft wall?
The esophagus.
The esophagus. So if you are too aggressive with an introducer or a bougie, or if you're doing a percutaneous tracheostomy and you puncture too deep, you can go right through that membrane and into the esophagus.
Creating a tracheoesophageal fistula.
Which is a nightmare complication.
And at the very bottom of the trachea, we have the carina.
The bifurcation. It's an incredibly sensitive area. If you stimulate the carina with your endotracheal tube, you'll trigger intense coughing and bronchospasm.
And anatomically, the two main bronchi that come off it are not symmetrical.
Not at all. And you must know the difference. The right main bronchus is shorter, it's wider, and it's much more vertical. It comes off the trachea at about a 25-degree angle.
Whereas the left is.
The left main bronchus is longer, it's narrower, and it's more horizontal. It leaves the trachea at about a 45-degree angle.
So gravity and simple physics mean things are more likely to go to the right side.
Exactly. If a child inhales a foreign body, it almost always goes to the right. If you advance your endotracheal tube too far, it will almost always go into the right main bronchus.
A right main stem intubation.
Yes, resulting in ventilation of only the right lung and collapse of the left lung. That's why you always auscultate both lungs after intubation.
We have mapped the entire natural airway. Now we have to talk about how to get access when things go wrong. This is where anatomy literally saves a life. Part E, cricothyrotomy.
This is the definitive final step in the can't intubate, can't ventilate, or CICO algorithm. You are bypassing the entire obstructed upper airway.
And to do that, you need to know one landmark: cold.
The cricothyroid membrane.
Okay, walk us through finding it. You're in a crisis, adrenaline is pumping, your patient is desaturating. Where do your fingers go?
You find the thyroid notch first. The V shape of the Adam's apple. It's the most prominent thing.
Got it.
Slide your finger straight down in the midline. You will feel the firm thyroid cartilage, and then you'll feel a distinct dip, a soft depression.
And then below that?
Below that, you'll feel the next hard ring. That's the arch of the cricoid cartilage. The depression you felt in between the two, that's the membrane. That's your target.
It's not a very big space.
No, it's about 1 by 2 centimeters in an adult, but it's very superficial, it's right under the skin, and it's relatively avascular.
We talk about two types of cricothyrotomy. Needle versus surgical.
Right. And needle cricothyrotomy involves putting a large bore cannula, like a 14 or 16 gauge, through the membrane. Then you connect that to a high pressure oxygen source for jet ventilation.
But that's a temporary measure.
It's a rescue measure. It allows for oxygenation, but ventilation getting CO2 out is very poor. You're just buying a few minutes.
Whereas a surgical cricothyrotomy is a definitive airway.
Yes. The scalpel bougie tube technique. You make a horizontal incision through the membrane, pass a bougie down into the trachea, and then thread a small cuffed endotracheal tube over it. Now you have a definitive airway you can ventilate through.
Are there times you wouldn't do this? Any contraindications?
The biggest one is age. In children, especially under 12, the larynx is small, it's soft, it's funnel-shaped. The cricothyroid membrane is tiny and very difficult to identify.
So what's the alternative in a child?
A surgical cricothyrotomy is relatively contraindicated. The preferred emergency airway in a small child is usually needle jet ventilation or an immediate formal tracheostomy by a surgeon if time permits.
Okay. Now let's pivot from that emergency procedure to Part F tracheostomy. Students often confuse the two, but they are worlds apart.
Completely different. A tracheostomy is usually a planned, elective, or semi-elective procedure for long-term airway management. And anatomically, it's performed much lower down.
What's the standard landmark for a tracheostomy?
The incision is made to expose the trachea, and the tube is inserted between the second and third tracheal rings.
Why that specific level? Why can't you just go higher?
If you go too high, say through the first tracheal ring, you are very close to the cricoid cartilage. This has a very high risk of causing irritation, cartilage damage, and later on subglottic stenosis.
And what's the danger of going too low?
If you go too low, down around the fourth or fifth ring, the trachea starts to dive deeper into the chest, into the mediastinum, and you run the risk of hitting major blood vessels.
Like the brachiocephalic artery?
Specifically the brachiocephalic or innominate artery, which crosses right in front of the trachea in that area.
And we now have two main ways of performing a tracheostomy, surgical and percutaneous.
Yes. A surgical tracheostomy is the classic open procedure. The surgeon dissects down through the tissues, retracts the thyroid isthmus, and can visually identify the tracheal rings before making an incision.
And percutaneous.
The percutaneous dilatational tracheostomy, or PDT, has become the standard in the ICU. It's done at the bedside using the Seldinger technique. You pass a needle into the trachea, then a guide wire, and then use progressively larger dilators to create the opening.
It's faster, but it's a blind procedure in some ways.
It is. You're relying on anatomical landmarks and bronchoscopic guidance, but you can't see the pretracheal blood vessels you might be going through.
Let's talk about the complications. The list is long and terrifying.
It is. The best way to learn them is to categorize them: immediate, early, and late.
What are the immediate ones happening right there during the procedure?
Hemorrhage is the big one, usually from veins in the neck or the thyroid isthmus. Pneumothorax is another if you injure the pleura. And of course, the most feared one is losing control of the airway during the tube exchange.
And the early complications in the first few days.
Infection of the stomach, subcutaneous emphysema if air tracks into the tissues, and tube displacement or decannulation before the tract has matured.
Okay, now the late complications. The ones that happen weeks or months later.
This is where you see tracheal stenosis, a narrowing of the airway at the stoma or cuff site, tracheomalacia, which is a softening of the tracheal cartilage, and the big one, the one you never want to see.
The tracheoinnominate fistula.
Yes. We mentioned the innominate artery earlier. This is where the tip of the tracheostomy tube arose through the anterior wall of the trachea and into that artery.
And the presentation.
It presents with a sudden, massive pulsatile arterial bleed from the tracheostomy site. It is almost always fatal unless you immediately recognize it, overinflate the cuff to try and tamponade the bleeding, and get the patient to an operating room instantly.
That's essential knowledge. Let's move to part G, where we integrate all this. Let's create a mental table for the listener. The examiner asks, compare and contrast cricothyrotomy and tracheostomy.
Okay, 4 columns. Column 1, indication. Crico is for CICO emergency. It's a life-saving rescue. Trac is for long-term ventilation or airway protection. It's maintenance.
Column 2, speed.
Crico takes seconds to minutes. Trac is an elective procedure that takes, 15 to 30 minutes or more.
Column 3, sight.
This is pure anatomy. Crico is high up through the cricothyroid membrane. Trac is lower down between the second and third tracheal rings.
And column 4, complications.
Crico has a high risk of subglottic stenosis if it's left in for more than a day or two. That's why it's always converted to a trac. A tracheostomy is much more stable for long-term use, but it has that risk of fistula formation.
And we must correlate this anatomy to the difficult airway assessment. We talked about Mallampati. What about thyromental distance?
Right. The thyromental distance is the distance from the thyroid notch to the tip of the chin with the head fully extended. Anatomically, this space is where the tongue has to be displaced into during laryngoscopy.
So if it's short.
If it's less than about 6.5 centimeters or 3 finger breadths, there is simply no room for the tongue to go. This predicts you'll have an anterior larynx, a very poor view, and a difficult intubation.
Same logic applies to a large neck circumference.
Exactly. A thick neck, say greater than 23 centimeters, implies there's a lot of excess soft tissue in the pharyngeal walls. That narrows the airspace and makes both mask ventilation and intubation much harder.
We're in the home stretch now. Part H, exam strategy. You are the senior faculty. I am the postgraduate student. What are the common traps I'm going to fall into in the Viva?
Okay, trap number 1 is definitely confusion of nerve function. I see it every single time. Students mix up the internal and external branches of the SLN.
What's the key to keeping them straight?
Just remember the mnemonic. The internal branch pierces the membrane to go inside the larynx where it deals with sensation. The external branch stays outside to exercise the one muscle, the cricothyroid.
Okay. What's trap number 2?
The orientation trap. It sounds so basic, but it's an immediate fail. The examiner will hand you a laryngoscope blade or a laryngeal model. You must hold the laryngoscope in your left hand.
Always the left hand.
Always. And you must orient the model correctly, as if the patient is lying supine in front of you. If you hold the thyroid cartilage backwards, it shows you have no practical understanding at all.
And trap number 3.
Confusing crico and track. When asked to point out the site for emergency surgical airway access, do not point to the middle of the neck. You must be precise. Point to the cricothyroid membrane.
The diagrams. We can't say this enough. For a 20-mark answer, you have to draw.
You absolutely must. And you should practice 3 specific diagrams until you can draw them from memory.
Which 3?
First, a simple sagittal section of the head and neck. Show the tongue, the soft palate, the epiglottis. Label the oral, pharyngeal, and laryngeal axes. Second, the laryngoscopic view. Draw a circle. Put the epiglottis at 12 o'clock, the V-shaped chords in the middle. Label the arytenoids. Third, a simple sensory innervation map. Draw a tube, draw a line at the vocal cords, label internal SLN above and RLN below.
If you can put those 3 diagrams in your answer, you are already ahead of most of the competition.
Way ahead.
All right, let's wrap this all up. A final summary. Give me the absolute must-know bullet points for the exam tomorrow.
Okay, here we go. 1, the nose. Remember, the inferior meatus is your path, and Kieselbach's plexus is your enemy.
2.
2, the pharynx. Melampati is tongue versus pillars. The piriform fossa is the target for your internal laryngeal nerve block.
3.
3, the larynx. The cricoid is the only complete ring, which is the basis for Celix.
4.
4, innervation. The external SLN is for the cricothyroid. The RLN is for everything else. Remember, bilateral RLN injury equals airway obstruction.
And 5.
5, emergency access. Crico is high on the membrane, track is low between the rings. Know the difference, know the indication.
And what's the perfect final sentence to put at the end of that 20-mark answer?
You must always end with a paragraph titled something like Applied Anatomy or Anesthetic Implications, and you summarize why this all matters. Something like, a thorough knowledge of these anatomical structures is therefore essential for the safe securing of the airway, the effective application of nerve blocks for awake procedures, and the execution of life-saving surgical airways in a cannot intubate, cannot ventilate scenario.
It ties everything back to patient safety.
Always. That's the whole point.
That's the perfect place to end. Listen, we know standing outside that exam hall is terrifying.
Yeah.
We have absolutely all been there. But anatomy is constant. It doesn't change. It's the one map you can rely on.
Visualize the structures we talked about. Practice drawing those diagrams. You'll be fine. Good luck. Go get those marks.
You've got this. This has been a deep dive into airway anatomy. We'll see you next time.